Thank you. I'm presenting this on behalf of Chenchen Bing, who couldn't be at the meeting today, but she deserves a credit for coordinating and conducting this study here. So my disclosures, and I want to also acknowledge the funding sources for the study, the NIH and CPRIT in Texas, as well as Celsion for providing us thermosensitive drugs. So the background for this study is, Dr. Kim set it up very nicely, but for many childhood cancers, upfront chemotherapy prior to surgical resection is very common practice and improves outcomes, preserves limbs. Doxorubicin is a broadly used chemotherapy for a variety of pediatric cancers. And so the motivation for us when we started this study and this project was something Dr. Kim alluded to, which is late toxicity. It's a very important issue. So cancers are cured, but later in life, patients come back with heart failure and other cardiovascular complications, and it can be linked to their doxorubicin exposure. Just a graph to kind of highlight the point from an international panel, the odds ratio of someone receiving greater than 300 milligrams per meter squared of doxorubicin is 30 times higher than an untreated person for cardiac failure. So there's something that's an important issue and an unmet need. And so the objective that we wanted to set out to do was to evaluate whether image-guided doxorubicin delivery at the time of treatment would be an effective strategy for pediatric solid tumors and to address some of these late issues. So this is a preclinical study, and so the technologies we were evaluating were thermodox, produced by Celsion. It's a thermally sensitive liposomal formulation of doxorubicin. I think many people in this room may be familiar with it, but briefly, when it's heated above 41 degrees Celsius as it circulates, it releases its encapsulated doxorubicin locally. And many studies by people in this room, including this podium, have shown that you get an increased local concentration of doxorubicin when you heat with this drug. And on the heating side, we were really focusing on the use of MR-HIFU hyperthermia. For some of our large animal studies, we were using the sonolive, and for our smaller animal studies, we use a small animal HIFU system. So I'm going to focus on one study today, which was a tumor growth control study. We utilized a pediatric human Ewing sarcoma cell line, implanted these into nude rats, so it served as a useful, relevant cellular pediatric tumor model. And we want to look at evaluating tumor growth delay when we combined thermodox with mild hyperthermia. The study design, pretty simple. Tumor growth was monitored in rats with MR imaging serially, and we had multiple groups, controls, thermodox alone, HIFU alone, and the combined therapy. So our question was, did the combined therapy have a therapeutic benefit? Few details. The study, the treatment was performed on day 9 after tumor implantation, primarily because at that point the tumor was about 5 millimeters in diameter, which was compatible with what we could treat with our system. We did 30 minutes of hyperthermia, and it was done on a 3T MR scanner, and we used a real-time temperature control to control the hyperthermia using MAD-MRI, which is a toolbox produced by Dr. Picardo and University of Calgary. We infused 2.5 milligrams per kilogram of thermodox over 5 minutes, and then for the remaining 25 minutes, just continued hyperthermia as the drug circulated. That was the treatment one time, and then we just did serial imaging every 3 days and followed these tumors using just a benchtop preclinical MRI, and looked at what happened. So just some treatment details. You can see the tumors on the top left image there, so well localized, small, targetable with our system. We also used, as Dr. Ranjan pointed out, a lens to sort of do a poor man's phased array. We basically could cover the entire tumor with hyperthermia using this approach. You can see the temperature control. So using this real-time temperature feedback, the blue line shows the mean temperature in the tumor ROI over time, very, very precisely controlled at 42 degrees Celsius for the 30 minutes, and the red and the green are the 90th and 10th percentile. So a nicely, a well-developed and designed system for this tumor model. And I think the results speak for themselves. So these are our 4 groups so far. We've done about a month of imaging. We'll continue this for 2 months, and we'll probably add some more animals just to bolster it. But as you can see, control tumors are variable but tend to grow. You can see their growth curve. Thermodox alone, since you haven't released the drug, doesn't really have a therapeutic benefit. HIFU alone has some effect, perhaps, on some animals and others not. This is not meant to be therapeutic hyperthermia. It's only a short duration. It's really meant to trigger drug release. And when you release drug at the local site, you get a very pronounced tumor effect. And what it looks like, I'll just show you the 2 extremes, control plus combined. You see, it's hard, hopefully the arrows you can see, but the tumor tends to grow over time. to encompass the leg until sacrifice, and you don't see that with the control. So the conclusions, it's a pretty, I think, self-explanatory study. The conclusions is that there's a very strong effect when you combine hyperthermia and thermodox in this particular cell line. And I think this is true of a lot of pediatric tumor cells that do respond well to chemotherapy. I think the message I would say is that accurate and adequate heating is critical to obtaining this therapeutic response and would be the same clinically. I'm not showing the results today, but we've shown that there's also no penalty to the cardiac exposure with this approach. In fact, rather than a penalty, there's a benefit. You can lower your concentrations and potentially reduce cardiac exposure, which goes back to the late complications. And so we believe that this approach warrants further consideration as potentially part of upfront chemotherapy, and we hope this data supports that clinical discussion. Thank you.
Question, Vic?
Hey, Rajiv, very nice talk. So I have one question.
Mm-hmm.
Do you guys draw blood after your treatments to look at the free doxorubicin levels in the serum?
We have in our previous rabbit studies, not in these studies at all.
I just mentioned it because I was involved with Brad in these earlier studies with thermodox at NIH, and we found that despite getting these enhanced levels of drug and therapeutic effects, that because of the limited extraction factor that you get even in the optimal conditions with these liposomes when they're heated at the optimal temperature, a lot of drug is still, the majority of the drug is actually recirculates through the body. And we found in one of our studies that actually you get corresponding significant increases, let's say if you do a flank model, in the other flank. And so much drug, and that kind of detracts from the kind of advantages of lowering cardiomyopathy when using encapsulated doxorubicin compared to free drugs. So I'm just wondering, I'm sure the extraction factor is better when you use one of these more sophisticated systems, but I think that's a factor that still needs to be looked at because it takes away a little bit of the benefits of deploying locally and also using an encapsulated drug.
Yeah, it's a critical question. I would say in the large animal studies, I think some of that is accentuated, those effects, when you go to smaller and smaller animals because you're heating a larger volume of the total animal. In the large animals, we don't see, we've looked at that very carefully, what happens to the heart as you do these releases locally here, and we don't see an increase compared to free drugs. So I think
but you do see increases in serum levels.
I don't remember, but yeah, probably, as you said. But it doesn't seem to result in increased cardiac accumulation.
Thank you.
I'd like
But it's an important question.
Like one comment I would like to say is that in the human adult studies looking at thermodox, you do see concentrations of dox. There has been very minimal, even with liposomal doxorubicin alone, minimal effects in terms of cardiac versus free doxorubicin. But at the same time, that may be actually beneficial for some of the metastatic sites, outside sites of local control. But also, regardless, the concentrations that are provided in the local area are far beyond what you would ever achieve with just systemic dox or lipodox alone.
Yeah, I think the therapeutic window, avoiding the toxicities is nice, but I think the real clinical thing to look at with the thermodox HIFU combo is the 50 times the amount of drug in the tumor plus HIFU than in a free drug in a remote muscle in a VX2 rabbit model from Ashish's previous work. So anyway, cool stuff. Thanks.